next speaker, Anurag.
So can I tell a small comment, sir?
Sorry.
Can I tell a
Yeah.
I think if you look at the multi-cert
He's got up
injectors,
to get his 1,000 rupees.
if you look at the multi-cert injectors, I think we have to evolve or move towards. I think right now, just because of the financial constraint, I think we have not moved into this kind of a technology because we need to, all our lenses should be a preloaded one. See, because when it is preloaded, you don't manipulate it, you don't damage the lens, less chance of infection, so on and so forth. So I feel eventually the industry will come to a stage where all lenses are preloaded, but the multi-cert is already in that level. And the second thing is the screw. That really will make sure that you don't have those surprises where you have these sudden jerks and the lens just pops out and you have complications. That cannot happen. It's like 100% thing. So that is the beauty of this particular injector, I would say, from my side.
So there are few chairs up front. The only disadvantage, I would say, one, you were talking about the cost, but apart from that, there's only one disadvantage, that if something goes wrong, you can't really put it back into the multi-cert injector because you need a different cartridge. You can't reload a lens. That's the only other advantage, but disadvantage. But I think that is where the industry is moving. Everybody is moving because it's the ease of insertion. But not every company has been able to have this ease of insertion as you are having in the multi-cert. That's what I feel, because there are lenses which get cracked often at times and things like that. But this is one where it has been almost excellent injection technique. Sonu wants to also get his 1,000 rupees.
Sir, scientifically, I feel only those small pupil cases where you exactly want to deliver in the bag, I think that is one very important place where, that long nozzle actually delivers the lens inside the bag. And that has really helped us, in small pupil patients.
So over to, sorry, you want?
Another point is, with these lenses, they're only going from strength to strength. They started with one of the beautiful injector system. And every lens that got added on the platform is only performing better. So that's the beauty of this, where it's a double winner. So
we have the great guy from Odisha, gin enthusiast, and which is your latest new car that you have bought, a Porsche?
The X5.
X5. Now you should take an X7. Anyway, so I think he's a great surgeon. It's always really a pleasure to talk to Anurag and to see his live surgery. Over to Anurag, please.
Thank you so much, sir. Good afternoon, ladies and gentlemen. As has been stated already, greetings and regards from the land of Lord Jagannath. Now, this was a patient who was pretty young, 45 years old, and unfortunately was one-eyed. He had lost one of his eyes when he was pretty young due to some firecracker injury. He had COVID in 2020 and had been on a course of steroids for a pretty long time. Probably the reason why he started having issues initially with his driving, particularly after sunset in the night time. He kept on ignoring it and neglecting it. Ultimately, he was not able to manage it anymore. And then he came. On evaluation, the patient had only one eye left, so I wanted to give him the best. I so wished that the patient would choose the femto platform, but the patient did not. And as it turns out, as we would find out in the end of this segment, that there was no reason why either me or the patient would regret that decision not to choose femto. The patient was not a suitable candidate for any trifocal or EDOF because his measurements were not pointing towards a perfect suitability. And despite of all the talks, all the discussions we have, I do not think any trifocal or any EDOF is free from the influence of angles. So his angles were high, and I did not choose those IOLs for him. I chose the Vivian X Impress, just like Rohit sir did a few moments back, which is an enhanced monofocal. So as you would probably find out, a lot of these patients, one-eyed patients, initially do not cooperate with you very well when you're trying to align the eye against the coaxial illumination of your microscope. So eventually they do, and it also depends on the type of illumination your microscope projects towards them, if it's very bright or you can manage with a little less illumination. This is the way I make my incisions, both side port and the main port together. And I always zero in on a 2.2 millimeter incision, come what may, the grade of cataract, the type of patient, whatever be the situation. And all three ports are usually made before any solution goes in. So no anchoring of the conjunctiva, and no solution goes in before all the three ports are made. Some amount of preservative-free lignocaine, just to enhance the cooperation from the patient. And then some viscoelastic. 99% of the time, I would just instill HPMC, which is a standard dispersive that we have in our hands just to keep the economy of the whole thing in the forefront. The capsulorhexis, again, I mean, just like any of us, I would prefer the cystitome first. If it's not permitting me, which happens in a few rare situations, I would revert to the Haldipurkar's forceps. Actually, that's my second go-to instrument if I'm not able to complete it with the cystitome. The rhexis size in any IOL is important, particularly for these advanced technology IOLs, wherein you want the centration of the optic has to be right at the center. It might not be very circular initially, but we should give our best efforts to make it as full moon and as circular as possible. It's a softish cataract. That's the reason why I wanted to femto it. It is a softish cataract, but the patient did not agree, as I mentioned. The fluidics in my surgeries always remain, it's almost similar. The IOP stays at 20 panel, the aspiration flow rate stays at 23 panel, and the vacuum stays at 450, also panel. This panel mode of selection of vacuum has come in after I got the active century. Before that, I just had a small tail off towards the fag end of the vacuum line. So let's begin with the phaco. In the left hand, I do not have the normal chopper that I would, the Chang's chopper that I normally use. I've substituted that with a much blunter Sinskey hook since the cataract is soft. These sort of nuclei actually cause issues for us. As they say, the softer nuclei are the harder bargains. So if you use power in these cases, there's a possibility of a chatter, and you might not get a proper hole. So what I'm doing instead is just holding it with vacuum and trying to chop it. And it happens. In majority of the cases, you can vacuum chop or even mechanically chop them, as you would see the secondary chop. So this is the primary chop, which has happened now. And quickly, the secondary chop would also happen. And I'm just keeping the phaco needle right at the point where the nucleus is and trying to levitate. One segment has come up already. We go to the frag mode. And the CDE, as you can see at the top, stands at 0, as we have already started emulsifying the segment. So this is one of the best ways, in fact, my go-to ways for handling very soft cataracts. Do not use power at all, because it actually doesn't need it. And as you would see, since this is an unedited video, this doesn't even take too much of time. So after the nucleus, the epinucleus, it almost forms a complex with it, comes out, and then we go to the cortex. No need to change hands and change instruments. The same phaco needle can do the job. The cortex removal from all around. Of course, you can do that only if you have a proper depth perception coming in from the instrument you're using to visualize. It just does catch the PC at times, but nothing to fret, because if you have control of the foot switch, it doesn't cause anything. So everything's out. Now the bag's ready to receive the implant. Hydro implant is a technique that I choose to implant all my IOLs. Before that, small BSS flush to the PC to remove some of the stub-on fibers that are there. And then finally, I knew that my previous speakers would harp on the injector system of this fantastic assembly, so I did not show that intentionally. I would go straight into the delivery part. This is the hydro delivery, and what I would just add on to whatever was being discussed a while back. Oftentimes, I have not even used viscoelastic in the cartridge. I've just pushed in some visco, and it's so slithery there. Such is the friction that has been lessened in terms of the covers that they have provided on the inner surface of the cartridge, that it moves in without any support of viscoelastic. You don't need any lubrication there. The second instrument, or the aspiration, just goes in to take out one fiber that was there subincisionally, and then the eye is ready to be formed. The CDE still stands at 0. So this is the reason why I said, neither I nor did the patient regret that he did not choose the femto. What you achieve with the femto is lessen the phaco energy, and we have not used any phaco energy for this particular patient. After forming the AC, just before, this is particularly true for toric IOL implantations in particular, I believe the surgeon should always watch the speculum being removed, because at that precise moment, there are occasions where the patient squeezes the eye and it egresses some amount of fluid, and the toric IOL particularly shifts its position. So I always watch as the speculum is removed, and the moment it shifts, we will see now the summary of the case. So the overall case time was 3 minutes and 49 seconds. Add to that the rhexis and the incision times. Energy used was 0. There was no ASM, active surge mitigation actuation. So despite of the low fluidics and basically a fluidic-based surgery, there was nothing that the machine did to, to mitigate the potential surge. And the total estimated fluid that we consumed in the process was 23 milliliters. So that's also something that you should keep in mind. So the tissue being safe and fine, the patient being safe and fine, the Vivinex Impress goes in. The next day the patient had, and my experience with the Vivinex Impress thus far has been, I think we have clocked around 100 implants by now. So contrary to what has been told to us by the manufacturers that it offers a defocus of 0.75, I have found the defocus to be more, consistently so. So I believe that the defocus is somewhere around 1.25. So at 50, it's either N10, that's the worst case scenario, and N8 most often. And almost 90 to 95% of my patients, even after unilateral implants, have achieved an N6 with a +1 add. I think I can count only 2 patients who needed a 1.25. One of them needed a 1.5, but rest all have been N6 with a +1. So the defocus essentially is not. And if you don't have any surface modification at the center, no rings, no photic phenomena, and you're getting a defocus of 1 to 1.25 diopters, I think this is nothing short of just phenomenal. Thank you so much, ladies and gentlemen, for your attention.